Hello everyone. Today we are going to talk about the last part of chapter 6, the motor part of the sensory motor system. And so in terms of motor or movement, there are three categories of muscle. We have smooth muscle that controls our internal organs, skeletal or striated muscle that controls movements of the body. And the skeletal muscle, right, it moves your skeleton, and striated because it actually looks striped or striated. I know there's some pictures in your textbook. And cardiac muscle, that's heart muscles. Um, so how do we move? Control of movement. Basically, we have axons that synapse on a muscle, and the synapse of a motor neuron with a muscle fiber is what we call a neuromuscular junction. So that's the synapse between a motor neuron, just a neuron that synapses on a muscle, and a muscle fiber. In skeletal muscles, axons release acetylcholine in this neuromuscular junction. That's the neurotransmitter in a neuromuscular junction. And each muscle moves only in one direction. All it can do is contract and moves in one direction. And so in order to have movement, like in order to move your arm up and down, like we can do, we've got different muscles that work in tandem that are what we call antagonistic. So one muscle tenses in order to flex or raise the arm, that's your bicep, and then another to straighten or lower your arm, that's your tricep. And so you've got two muscles that work in tandem, and when one is activated, your arm goes up. When the other is activated, your arm is straightened or lowered. And excuse me, EMG, electromyography, that is a machine that is able to record electrical activities of your muscles. And so here we've got pictures of the neuromuscular junction, and these are where axons, here you see the myelinated axons synapsing right here on a muscle. So instead of synapsing on another neuron, the synapse is with a muscle. And so it's that activation from the neuron sending acetylcholine in the neuromuscular junction that causes the muscle to move. And again, here you are, where we've got an axon that terminates or ends in contact with a muscle fiber, and the type of neurotransmitter that's released is acetylcholine, and that's going to cause the muscle to move. Myasthenia gravis is an autoimmune disease where the immune system antibodies attack acetylcholine receptors. So remember, this is these motor neurons are releasing acetylcholine. There are acetylcholine receptors here on the muscle that would act once acetylcholine binds. And so what happens is that people get weak and rapid fatigue of muscles because the motor neurons can't produce their maximum level of acetylcholine, and acetylcholine isn't being used in an appropriate way. And it's treated, this is treated by drugs that inhibit the enzyme acetylcholine esterase. And so what that means, acetylcholine esterase, oh, I'm going the wrong way, is an enzyme that's in the synapse that breaks down acetylcholine once it's released. And so if you use a medication that inhibits acetylcholine esterase, what that means is whatever acetylcholine is still out in the synapse is more likely to bind. So it's not being broken up by that enzyme as quickly, and so basically it enhances the effect of whatever acetylcholine is there. Proprioceptors are receptors that detect the position or movement of a part of the body and help regulate your movement. That's really important in terms of movement, is you not only need to be able to move, but you need to know where your body is. How bent are your legs? How bent is your knee? Where is your arm? In order to properly move around the environment. And we have two kinds of proprioceptors. We have something called a muscle spindle that's buried deep in the muscle fiber, and that responds to stretch, how stretched out your muscles are. And then we have something called Golgi tendon organs, and they're sensitive to how tense your muscles are. And so by knowing all the different muscles in your body, how stretched they are and how tense they are, your brain is able to figure out where your body is in space. And that's pretty amazing when you think about it, because we don't think about it at all. It all happens without our knowledge, but yet our brain is making these calculations all the time. Voluntary and involuntary movement reflexes are involuntary automatic responses. Something like your pupil constricting when you get into bright light. You don't think about it, but your pupil constricts and lets in less light into your eye. If somebody blows on your eye, you automatically close your eye. That's another reflex. So these happen without any thought. Infants, there are specific infant reflexes. If you take a developmental psychology class, you'll hear about these. There are many of them. Here are just a few. So infants have a grasp reflex, where if you put anything in their hand, they automatically grasp at it and hold it. They have a Babinski reflex, which when the sole of the baby's foot is stroked, they extend their big toe and fan out all the others. And they have a rooting reflex, which when you touch the baby's cheek, they will reflexively automatically turn their head to that side. Now, these infant reflexes, most of them go away as babies develop. A lot of the infant reflexes are important for helping the baby survive. For instance, that rooting reflex, when you touch a baby's cheek and they automatically turn their head, that's important because usually when something's touching a baby's cheek, it means there's food there. So they turn their head. They also have a sucking reflex. Anytime you put something in a baby's mouth, they start to suck. Again, important for survival. And then as babies mature, those infant reflexes go away. The cerebral cortex is important for complex actions like writing, but less voluntary movements like coughing, laughing, crying, those are controlled subcortically in the subcortex, right under the cortex in the white matter of the brain. The motor cortex can direct contraction of specific muscles and a combination of contractions to produce a specific outcome. Other aspects of the cortex that are important in movement, the posterior parietal cortex, so the back of the parietal cortex, keeps track of your position in space. We talked about visuospatial processing and where your body is in space. And so if the posterior parietal cortex is damaged, you can see an object, but can't figure out how to actually pick it up or step over it. It's hard to know where that object is in relation to your body. It's the parietal cortex. Primary somatosensory cortex, we talked about that in the previous lecture. That's important for touch information, and so that's really important for grasping objects, lifting objects. You need to be able to receive that touch information, how hard you should grasp something, what is the texture of that object, and so all of this goes together to make coordinated movements. Also, again, here's our side view of the brain. The prefrontal cortex is active when you're planning or calculating a possible outcome of a movement. Damage here results in badly planned movements. People might shower with their clothes on or put salt in their tea. And this prefrontal cortex, interestingly, is inactive during dreaming. And dreams are usually very haphazard in terms of what you do, not very planned. And so it seems like that prefrontal cortex is not working as we're dreaming. Premotor cortex, that's right here, so still in the frontal lobe, is active during preparations for a movement. So before you even make the movement, there are neurons that are helping your body prepare to make a movement. And then here we have primary motor cortex. So this is the frontal lobe. Here's central gyrus, and right before that is the primary motor cortex, this red strip. And then right behind that in the parietal lobe, this is primary somatosensory or touch cortex. Okay, so those two are kind of right bordering on each other. Motor cortex, the very back of the frontal lobe, and primary somatosensory cortex, the very front of the parietal lobe. Connections between the brain and spinal cord. So messages from the brain reach the medulla and the spinal cord through dorsolateral or ventromedial tracts. So again, for motor control, we're sending a message from the brain, and then it's got to go down and out to our muscles. So the dorsolateral tract, it's also called the pyramidal tract. This originates from primary motor cortex. So here we're sending a message from primary motor cortex. In the medulla, which is right here, I'm sorry, not right there, right here, that's the midbrain. In the medulla, the axons cross over to the opposite side of the spinal cord. And then in that way, right, information from the right side of the brain controls movements on the left side of the body. Information from the left side of the brain controls movements on the right side of the body. So the axons cross at the level of the medulla and then go down and exit to muscles to control your hands, fingers, toes. And damage in this tract means loss of fine movements. Again, here's primary motor cortex. It's set up in a topographic or in a map kind of way that represents the body. Similar to primary somatosensory cortex. And so again, you've got different motor or ability to move, chewing, salivation, tongue, throat, jaw, lips, face, hands, very large representation of the hands because we use our hands to do so much and such fine movements, wrist, elbow, etc. And it's also set up in this motor homunculus, again, where we are able to do more finer movements like our hands, our lips and mouth for talking, our tongue. Those are represented a lot in a lot greater area in the motor cortex, and that gives us the ability to have much more specific movements. The ventromedial tract of axons from the brain to the muscles, those include axons from both primary and supplementary motor cortex. These axons actually do not cross to the contralateral side, so they come from the brain and they stay same side because these are axons that control bilateral movements. So things that actually use you can't move one side without the other. So movements of your neck, if you think about it, you can't move one side of your neck without moving the other. Or your shoulders, really when you move your shoulders, if you move one, the other goes in the other direction. And the trunk of your body, right? Twisting your trunk, you can't move one side without the other. So this is not contralateral, it's what we call ipsilateral, stays on the same side. Damage here impairs walking, turning, bending, standing up, etc. The role of the cerebellum in movement, this is associated with balance and coordination. It's important for motor control and has more neurons than the entire rest of the brain, which is pretty amazing. Helps with fine-tuned, skilled movements. Damage to the cerebellum causes trouble with rapid movement that requires aiming and timing. So clapping your hands, people have trouble clapping their hands, getting their hands to meet together in the center. The finger to nose task, if we were face to face, I would have you try to do this, but basically extending your pointer finger out in front of you and then bringing it back and touching your nose, and then extending your finger out in front of you and bringing it back and touching your nose. That's a task that people may have trouble with when they are also drunk, when they're intoxicated. And we'll talk about that when we get to drug use, but basically alcohol affects your cerebellum first, and so that's a really good test to see if someone is intoxicated. Common symptoms of cerebellar damage include abnormal gait and posture. Gait is walking, especially something called ataxia, which is loss of coordination of the legs. When you think about walking, there is so much that has to be done in order to walk properly. Your balance, you move your legs, you also move your arms. One leg moves up, one leg is back. You have to switch your balance. So much has to happen, and so when the cerebellum is damaged, we often see a loss of coordination in terms of walking. And the idea of decomposition of movement is that gestures are broken up into segments. Instead of being executed smoothly and normally, it's like their body has to kind of break each thing down and do one part at a time instead of a smooth, coordinated movement. Basal ganglia, that's another group of subcortical structures that are important for movement. The basal ganglia consists of the caudate nucleus, the putamen, the globus pallidus. Stores sensory information that guides your movements, helps you learn rules and organize sequences of movements into smooth automatic whole. It is important for organizing action sequences into chunks or units, like learning how to drive a car, habit learning. So movements that are performed by memory rather than a sensory control, and also for initiation of movement, starting of movement is really important. The basal ganglia is really important for. And Parkinson's disease is a neurological disease which eventually leads to cell death, particularly in a part of the brain called the substantia nigra. Substantia nigra releases dopamine. Dopamine is very important for movement in the substantia nigra and then for our bodies, and basically results in decreased excitation of cerebral motor cortex. And so you can see this is the substantia nigra right here. And these areas here, this would be normal. The dopamine is very black in color, and you can see diminished substantia nigra. The black color is almost all gone in patients with Parkinson's disease. And this is a midbrain structure, middle, you can see right here. This is like a section right through the middle of this person's brain. Here we are looking down on the brain. There are the eyeballs, and there's that substantia nigra. This is a gradual decrease in neurons in the substantia nigra that leads to Parkinson's disease. And people don't get symptoms until about 20 to 30% of the neurons have already died off. And the symptoms of Parkinson's disease are rigidity, very rigid, muscle tremors, slow movements, and a hard time starting physical or mental activities. That's a problem with initiation. Being very slow on cognitive tasks, and some depression. Possible causes of Parkinson's disease can be genetics, especially in early onset Parkinson's disease. If one identical twin has early onset Parkinson's disease, it's a good predictor for the other twin, but less of a good predictor after 50 years of age. So later onset is not, doesn't seem to be as genetically controlled. There seems to be 5 genes that are more common in patients that have Parkinson's, but we don't have a specific gene yet that is for codes for Parkinson's disease that we know of. Another possible cause of Parkinson's is exposure to toxins. And there's a movie that you'll be watching this week about this designer drug, MPTP, which seems to destroy dopamine releasing neurons and leads to a Parkinsonian-like syndrome. Cigarette smoking and coffee drinking are also related to a decreased chance of developing Parkinson's. Research suggests marijuana use increases the risk of Parkinson's disease. Damaged mitochondria of cells seems to be a common factor that increases the risk of Parkinson's disease. Most common treatment for Parkinson's is a medication called L-DOPA, basically because they're missing dopamine. They have loss of dopamine. L-DOPA is a precursor for dopamine that you can take that crosses the blood-brain barrier, because not everything crosses, but this does. And then once it's in the brain, it converts to dopamine and can be used in the brain as dopamine and helps to restore normal movement. It's very effective in early to middle stage treatment, but some patients don't benefit at all. It also doesn't stop the progression of the disease. So as patients continue to lose these dopamine producing cells, they continue to have more and more symptoms. Also, dopamine enters other brain cells and causes other side effects like nausea, restlessness, sleep problems, low blood pressure, hallucinations, and delusions. And then last disorder of the motor system that we'll talk about is Huntington's disease. This is a very severe neurological disorder that affects 1 in 10,000 people. It causes extensive damage to the caudate nucleus, putamen, globus pallidus, and in the cerebral cortex. The symptoms often appear between age 30 and 50 years old, starting with jerky arm movements, then a facial twitch, tremors, and then this writhing where they just can't stay still. Patients can't learn new or improve their movements. This disorder includes depression, memory impairment, anxiety, hallucinations, and may originally be misdiagnosed as schizophrenic, and eventually leads to death. And it's a very, very difficult disorder, and we don't have any treatment for it. You can see here, it's a brain of a patient with Huntington's. You can see loss of so much brain tissue compared to a healthy brain. There's no treatment, like I said, that's effective in controlling the symptoms or slowing the course of the disease. It does end in a very, very difficult death. And there are now, and there are now pre-symptomatic tests that can identify who will develop the disease. It's totally genetically controlled, and it is a dominant trait. So if somebody has the gene, they will develop the disorder. And so now you can take a test to know if you have the gene. And the question, there's a lot of ethics about that. Would you want to know early on if you had the gene? If you knew that you were going to have this disorder that would then, there's no treatment for and that leads to an early death. Now, typically, it's inherited by the genes your parents have, so very often people know if this runs in their family and know if they're at risk for it at all. But if it did run in your family, if you know a parent had it, then would you want to take this test to know if you also inherited the gene? Kind of an interesting bioethical question. All right, well, thank you very much.